Suicidality, Assessment and Action, presented by Kenya Rocha, LMHC, with Mosaic Family Counseling Center, Incorporated, in collaboration with the Iowa Department of Human Rights. The purpose of this presentation is to support and educate service providers in dealing with clients who may have suicidal tendencies. We will learn to assess the lethal intent of someone who shows suicidal thoughts or behaviors. We will also learn to measure how likely someone is to act on their thoughts. We will learn what to do when you believe someone has demonstrated a credible threat. The terms around suicidality can be confusing, and they mean different things. Our review of these terms is to help you understand the meanings and differences between them. It will help you think about the different definitions we use in discussing suicidality and how to assess situations you may encounter so you feel more able to help. Definitions. You might hear several different ways people talk about suicidal behaviors. Throughout the section, we're going to unpack these different terms. Suicide, suicidal ideation, suicidal gestures, suicidal attempts, suicidal completion, self-harm, and lethality. Suicidal ideation is just that. It's an idea, a thought. And although this thought comes from a very negative place, this can be a response to living in personal, stressful situations for long periods of time with no resolution. Most people have had this at one time or another. Thoughts might be, what if I just didn't wake up in the morning? What would happen if I wasn't here anymore? The thoughts might be intrusive thoughts that come from seemingly nowhere. Maybe they are having visions of seeing oneself no longer living. There is no real plan, but the thought is there. Thoughts can be anywhere from non-specific, of just disappearing into thin air, like transient thoughts, or to thinking, what would happen if I killed myself, as a solution to the problem. These thoughts can be anxiety-provoking and promote enough fear to ask for help. Sometimes the fear of these thoughts can move us into making a more positive change to better our situations. This can resolve organically or naturally when life gets better, or they begin to take steps to make things better. When people voice their thoughts about suicidality, it's important to take it seriously. They may have been thinking about it for a while, and the thoughts are just getting worse. Oftentimes, suicidal ideations are not concrete. They're just an urge or a way to get someone to take them seriously. There is an unmet need, and they have had no success at getting it met. They may feel there is no resolution with their most important relationships, and they're burned out from trying to make things better. They may feel worthless or insignificant in the world. Suicidal gesture is an action performed for show in the knowledge that it will have no effect. It can be seen as a practice act. The actual goal is not to die. It often happens in an emotionally intense moment. It may be a way to communicate the severity of how the client feels and draw attention to the problem. It may be an act that irrationally, in the moment, the person may believe will make them feel better. It is an act against the self. It can be seen as a cry for help, and it can be fatal if an act has been committed to get someone to save them. It can be shallow cuts on the wrists, threatening to do something specific, telling you they did something they didn't do to pull attention to the problem and get help. Sometimes a gesture can be seen as someone who survived an attempt. Their goal was not to actually die, but to put their life on the line in a gamble to see if someone will respond in enough time to save them. This is a critical phase of suicidality. An example would be someone takes the pills and tells their parents or someone close to them, or calls 911 in hopes that someone will get there in time. Often clinicians do not like the term gesture because in its most severe state, it is sometimes fatal. When someone engages in self-harm, this can be seen as a suicidal gesture if the act is severe enough. However, the goal isn't actually die, but the thoughts are there. This is a progression from the idea stage and more severe. Suicidal attempt. An attempt may be the time when one gets help, especially if they end up with professional intervention. An attempt can end up with one in the hospital and can end in completion. You may see someone preparing for an attempt with behaviors of collecting supplies, like pills, razor blades, saving back alcohol or other drugs, and practicing tying a noose, or talking about where or what they're going to do. They may even write letters to those that they love. Many times an attempt is an action meant to get attention without the actual intent to die, but they may think, if it happens, so what? Some other things you may see when one is preparing for an attempt can be sudden happiness. They may feel like they have a resolution to their problems and present very content, like they're doing well. They may display goodbye behaviors too, like being more social with people they haven't seen in a while and giving away belongings. Saying things like, no matter what happens, I want you to know, I love you, you're a good friend. All of this isn't your fault. After the attempt happens, many emotions come up for both the victim and the loved ones, who may be angry with the victim or feel sad and helpless, guilty or hypervigilant, and the victim may feel humiliation, worthlessness, and anger as well. All of these emotions are normal under the circumstances. Victims may feel like their brain is in a tangled mess, or suddenly have clarity that serves as a wake-up call that can make them feel grateful for surviving. Our responsibility here is to help the victim find help as well as the family. This can be the beginning back to a place where they want to live, and they will need support. Hospitals. It's a good idea when someone has identified the desire to end their life or make statements that concern you to take them for an assessment. Our system is set up to help people when they're at risk of completing suicide. When you take someone to the hospital for an assessment, they'll be asked several questions. The most important one is if they intend to die. If the client says they do not intend to die now, they will most likely not be kept. If the client says they may engage in an attempt if they leave and they don't feel safe, most likely they will be kept. If the client says they do not know if they will or not, they still may not be kept. The only time that they will be kept is if the threat is credible. If the person doing the assessment believes that there is a chance that this person will complete suicide if they leave the hospital at that time. This completely depends on what the client says when they're in the assessment. Oftentimes, when you take a person to the hospital, they're calmer. The need was met for the moment. Maybe they're embarrassed that they made such a fuss. Maybe they're angry, they didn't want to go to the hospital. Maybe they wanted somebody else to respond, a parent, a friend, a lover, to help them. Maybe they'll be afraid of what will happen in the hospital and just flat out say they're not staying. Maybe their worst fear is that it'll mean that they're crazy if they go to the hospital. They may be just simply afraid of dealing with the problem in that moment. Suicide completion is an action taken against the self that ends in death. You may hear phrases like so-and-so completed suicide or committed suicide. That is when the act against the self actually ended in death. Self-harm is when people do things to hurt themselves, actions taken to damage the self. It may be done to relieve stress or act on internalized anger, to account for a sense of hopelessness or when they feel numb to try to feel anything. It may be to have control when they otherwise feel they have none. Oftentimes you will hear someone refer to this as cutting, burning. They may pinch themselves to the point of bruising, not allowing themselves to heal from wounds, picking scabs repeatedly. They may inflict a wound purposefully just to use it as a way of keeping the wound open and feeling. Those who engage in self-harm have low coping skills to deal with problems. Low self-esteem or feelings of worthlessness. Maybe they don't feel safe in their relationships, either with a family of origin, peers, or significant others. They may have attachment deficits that go back to early childhood and difficulty creating new relationships. Self-harm is a way to feel something in the absence of feeling or a diversion to feeling emotional pain. Some less obvious ways of self-harm can be camouflaged in more normal behaviors, like the ones listed here. Eating behaviors, overusing any substance, driving recklessly, engaging in unsafe sex, or other emotionally harming behaviors. However, they can be seen by those that love the person as acting out, causing problems, or simply just don't understand the behavior. They may overlook the behaviors because they don't know how to deal with them. The major thing to remember here is that the person who is self-harming is in pain. They need help and another way to cope. Oftentimes, people who are in abusive situations or who have experienced relational trauma or sexual abuse may self-harm to release the emotional pain of the trauma. Relief is short-lived and people can become desensitized to what they're using. So to be able to get the same effect, the self-harm grows more severe over time. This behavior often leads to increased depression, addictions, and can lead to suicidal behaviors. Self-harm behaviors can also turn into an addiction, starting off as an impulsive behavior. The act of harming has a physiological effect. The body actually releases endorphin-like chemicals that create a numbing of the area receiving the harm, and that evokes an emotionally calming effect. This can be a precedent for the harm turning into an addictive impulse. Lethality. How likely is someone to commit suicide? Is suicide a credible threat? Is it serious? The plausibility of death. How likely is this person to follow through and advance in the stages of suicide? Learning to measure lethality will help you to know what steps to take. Prevalence. Here we will look at the statistics relevant to suicide in the United States. Suicidal behavior statistics in the United States in 2018. According to the CDC and SAMHSA, many more people attempt suicide than complete suicide. There are over 48,000 deaths by suicide in our population each year, with 443,000 hospitalizations for suicide, and that number doesn't even include our youth. We have over 1.4 million adults reporting attempts of suicide in 2018. As you can see by this graph here, women are at greater risk for suicidal ideation, attempts, and medically treated attempts than men. However, men die by suicide at a higher rate than women. In Asian or Pacific Islander populations, suicide rates peak later in life, 85 and over. This is a different pattern than is seen in the overall U.S. population where suicide peaks in midlife. Among Black populations, suicide rates peak during adolescence and young adulthood, then decline in midlife. This is a different pattern than is seen in the overall U.S. population, where suicide rates peak in midlife. Black Americans are more challenged by our society during their earlier lives, where the majority begin to face more challenges in midlife. Among Latinx populations, suicide rates remain somewhat steady across the lifespan. This is a different pattern than is seen in the overall U.S. populations, where suicide rates peak in midlife. The patterns of suicide death rates among white populations and the suicide death rates of overall U.S. population is similar across the lifespan, peaking in midlife. The suicide death rate for white populations is higher than the overall U.S. population across the lifespan. However, per capita, we know that Black Americans have a higher suicide rate within their group than do white Americans. Because the white population is the majority, perhaps it makes sense that the overall rates follow the same patterns. But this is cause for us to think about what happens in each population as a result of their particular existing variables. According to a youth risk behavior survey done in 2017, 7.4% of youth in grades 9 through 12 attempted suicide in that last year. Of those who attempted, 9.3% were females, 5.1% were males, 9.8% were Black students, 6.1% were white students. 2.4% of all of these required treatment, yet 3.4% of the Black students required treatment. Victims of suicide see this action as the only way out. Attempts are often a cry for help, but it's not always seen as a cry for help. Often a parent has seen progressively more self-harm behaviors, threats, or emotionally intense responses and become desensitized to the message the child is trying to have heard. This happens because the parent simply doesn't understand what to do. Feeling inadequate to deal with it, they sometimes become upset because they don't know what to do, or the child closes down because they feel helpless to make someone understand. This makes it hard for the family to heal, the child to be heard or helped. The whole family needs help here, not just the individual. Often students of color feel they must make more severe attempts because either they are trying to complete or don't believe they will be heard if it isn't severe enough. They also have to deal with the systemic biases that make them believe their needs don't matter, they see as validated every day in our society. Black Americans make up only 13.44% of the population as a whole, but have a higher percentage per capita for attempts on their own lives in all settings. These numbers have the power to open conversations to promote societal changes, but it also shows how much support this population needs. In this next section, we will explore possible causes to suicide. Depression is rage turned inward toward the self. Internalized negative language ruptures our relationship with the self. Rage is also the urge to kill. Depression is living in a body that fights to survive with a mind that tries to die. It's a very dichotomous position to be in, very confusing for the victim. I think this quote is very much like what our people who have suicidal behaviors and thoughts feel. When you ask someone, "Are you okay?" and they tell you, "I'm fine," but you see the look in their face and you know that there's something wrong. This picture makes me think of people that I've been in that situation with, asking them if they're okay, but seeing the shadows. And then I kind of know they don't know how to ask for help. They don't maybe feel that they're worthy of help. They want help, don't know how to go about getting it, maybe feel ashamed or embarrassed. This picture depicts that situation pretty well. In spite of the pictures that you just saw, I really thought this quote was really important. It's what we want people to know. We're all beautiful from the tips of our toes to the depths of our soul. We all have something to give, and it's unfortunate that people who turn toward suicide or suicidal ideations and behaviors don't know that about themselves. They don't own that truth. Suicidal behaviors can be seen as symptoms of deep depression or because someone's mental health is unstable. The different causes include a lack of positive relationship with self, lack of positive relationship with others, not knowing how to access help, seeing others as not helpful, even though they're doing their best, feeling hopeless, having overwhelming emotions, and chronic mental illness. Although depression can be the beginning of the slide into suicidal thoughts and planning behavior, it comes from feeling overwhelmed with life circumstances and a belief that things can never get better. It comes with a loss of hope that there is even help. Fear and anxiety set in and create a cycle of fear and sadness that keeps them depressed. As a provider who sees people dealing with big problems in their lives, you can ask certain questions if you see someone who normally handles life's problems with a passion and fire begin to act helpless and hopeless. I truly believe that mental health is exponentially improved when one can identify a safe person that they connect with on a deeper level, someone they see as caring and that they care for. Our very lives depend on this need. Our environment greatly impacts how we feel and live, how we see positively or negatively, if there is hope or if there is not. We take our cues from each other and our environmental tone of the times. We live in an ever-changing environment, and our feelings of threat from our community can be relatively high based on our status as minority, economic solidity, and the ability to identify someone to help. Being safely connected to the community is imperative, and right now this is being threatened. At the time of this writing, our country is in the middle of a pandemic, a world health threat that caused everyone to respond differently, but mostly in fear and for good reason. We are responding as if we're in danger. We do things we believe will keep us safer. When this threat is over, it may be hard to believe. It can be difficult for our minds and the part of our brain focused on survival to operate as if it's no longer in danger. We as a world have experienced a traumatic health scare. Many people have lost loved ones, seen illness and suffering. Others have been treated poorly. Even when treated well, those who are deemed essential workers are forced to be exposed to this health threat daily with no real end in sight. We have a hard time trusting authorities about navigating the results. People who serve others are essential, and while employers try to ensure safety and security and show appreciation, just the fact that you're facing the constant threat of harm that could cause death is stressful beyond words. Essential workers stay strong and continue to work because they have to earn a living and they truly want to work. At times, workers may feel underappreciated as the stress of doing more work in less time is put upon them, or perhaps your job was lost and you were not able to work because your company closed. Trying to find another job in this time is close to impossible, and the fear of returning to work brings thoughts about how you can be safe. The state's process of opening up brings a mixed bag of emotions: anxiety, happiness, a sense of security, that things might get better, but then a question of if it's a false sense of security, and then more confusion and relief. Many people are having those same thoughts, and they are normal. Unfortunately, we cannot control anything but our response to it and make decisions about how we will take care of ourselves during this threat. I sincerely hope we will have a positive resolution soon to the world situation. This contributes to our mental health. Also, at the time of this writing, we are experiencing civil unrest, a time when racial discrimination and tensions are coming to a point that cannot be ignored. It is difficult to discuss the topic and often avoided. Discrimination is not acceptable, racism is not acceptable, and white privilege needs to be identified and removed by learning about it and teaching about it. Being intentional in our work towards inclusivity and equality. Racism, discrimination, judgments, and inappropriate power directly create stress, anger, feelings of oppression, negative behaviors, hurt, sadness, terror, and rage. Stress related to racism and discrimination affects physical and emotional health. It inhibits the ability to meet educational, occupational goals, which further adds stress and decreases resilience, keeping us in a negative stress cycle, which can add to the depression and state of hopelessness that causes suicide. We have a responsibility to promote emotional wellness of all of our children, and racism is practiced in childhood, with the impact of white privilege and discrimination beginning early in life with seemingly insignificant attitudes and behaviors that promote the majority as superior. While children don't even know they have privilege and they perpetuate it without intention, but being taught about it, it can change. It can also give us as helpers a way to push for change. We are seeing more and more people stand up for each other, stand with each other, and support one another. It is difficult for anyone who is in a minority group to feel safe in their environment. Standing together with the same goal of equality and harmony can relieve many stresses on each other and our children. It is important when identifying any self-harm, suicidal ideation, or behaviors that we consider these messages we are receiving from our community and the systemic ways we are affected. We feel alone in it, like it's our burden to bear with no help. Societal influences have made it difficult for each of us to reach out and say, hey, are you feeling this too? What can we do about it together? We say we need to stand together, but cannot be realized until we reach out, say we're hurting, and talk about it first. Helping your clients speak about the things we don't normally speak about can be a first step to healing. Connecting with them on this level, and that can impact their lives in an enormously positive way. Stages of change. Learning about the stages of change can help us review our clients and measure where they are in the process of change, of the progression towards change. You can tell if they're ready for change and support them in making it to the next stage. It also helps us know what to expect from our clients as they're going through the process. Stages of change apply to every situation. We have pre-contemplative stage, We don't know there's a problem in this stage, so we're not even considering change. Contemplative, we realize we have a problem. We begin to see how it affects us and think about needing to make changes. Preparation phase. We identify what has to happen for change to take place, and we're deciding what we're willing to do and when it needs to happen. Action stage of change. We engage in behaviors that affect change. They might be small behaviors, medium, or big behaviors. They may be some of the things we identified that needed to change, or it might be all at one time. Then we have maintenance. I like to call this the assimilation phase because we learn to live with the changes that we've made and get used to them so they become more normal. We have relapse. This is when we go back to the old ways. Usually not all the way back. It's really important to point out here that when any of us have a relapse and engage in old behaviors that we don't want to do anymore, it feels really bad. It makes us feel like we're failures, like we can't do it. So it's important to support your clients through this time and let them know that they've made progress, that they're okay, that it's part of the process to relapse. So it's like sort of like one or two steps forward and a half a step or a step back. Any one of these stages can last a short amount of time or a long amount of time. We generally go back and forth through these stages until we die because we're constantly changing. When we have something big we feel the need to change, we focus on it more intentionally, and we can sometimes make big change. But it can also be very difficult to employ change on a level that we can see benefit. It will feel very slow. If you look at where you started, you can see the progress of changes in your life. I challenge you personally to look at anything you've ever wanted to change and apply these stages to it. Are you further now, even a little bit, from before you began? It's important to notice that we do go through stages for change. It's important that we help to support our clients through them. Let's take a deeper look into behavior and how we respond to an internalized need, sort of the whys of behavior. Very simply, it can be broken down to these things. We need connection with significant people in our lives. We need safety in our connections, in our environment, and internally. Every behavior is either running to or from something, specifically to get a need met. Everyone does the best they can in the moment that they're doing it with what they know until they know more. Because we need connection and safety, people do not normally hurt others on purpose with that sole goal in mind, unless it is themselves, because they have no hope for positive connection and safety. So ask yourself, what is the unmet need here? What is the best interpretation of the person's behavior? What resources do we have to help them get those needs met in a way that is more productive and helpful? What to look for. In this section, we'll go over some warning signs. Some warning signs can be seen as big behaviors. Some of them might not be. Maybe the person has talked about dying. There might be a change in their personality. They're doing things that they haven't done before. Maybe they're not taking care of themselves, or they're engaging in other behaviors that might be self-injurious. Recent loss, hopelessness, substance abuse, isolation. Maybe they've been recently victimized by something or someone. Engaging in disturbing artwork, sudden interest in dark things, previous attempts, new impulses or statements, making plans to give things away, uncharacteristic and sudden happiness and peace for seemingly no reason, low or no connection to others. Any one of these things alone may not mean a big thing. However, if somebody has had a history of suicidal impulses and any of these things are coupled with that, this is the time when you really want to look at what's going on for them and check to see if they're safe. Measuring the risks. When we're measuring risks, we want to get a full picture. We want to ask them about ideation, planning, and their behaviors. So we want to know how frequently they're having the ideas, how intense they are, how long they last. How many times in the last 48 hours have they had ideas about suicide? In the last month? And when was the worst ever? When it was really right there in their face. For planning, we want to know about what their timing is, like when they would do it, what location they would do it in, how serious is the plan. Do they have availability for the objects or the ways that they would do it? Have they prepared to do it? For behaviors, we want to know if they followed through on any attempts in the past. Have they started to and then aborted the idea? Have they rehearsed, like trying to tie a noose or loading a gun, saving back pills, hiding blades, those types of things, versus non-suicidal, non-injurious actions. You also want to measure the intent, the extent to which the person expects to carry out the plan and believes the plan to be lethal versus self-injurious, and other outcomes, like do they expect somebody to come? Are they going to call and reach out? Ambivalence, the reasons to die versus the reasons to live. It can be very helpful measuring these things when you're trying to give someone a reason to live. Prevention. In this next section, we will explore ways to help prevent suicide. This infographic is a wonderful reminder. When working on prevention advice, watch for signs of distress and changes in the behaviors as we've discussed here throughout this presentation. Then ask if they're having suicidal thoughts, and don't worry about offending them if they're not. This is an important time for them to hear that they're important enough that you care enough to ask. Remind them that it will pass. This is a message you can give them about all big feelings, thoughts, intensities that happen that prompt suicidal thoughts or behaviors. Help them get to therapy. Someone to talk to professionally can relieve the stress on the family as well, so that the family can be more emotionally present for the client instead of trying to manage or control them or be in constant fear of what might happen. The National Suicide Prevention Line can be a wonderful resource for individuals and family members alike. When people lack these things, it enhances feelings of loneliness, desperation, and sadness, and can cause a slide into darkness. Connection to others gives one a sense of validation and worth. Empathy helps one feel understood and brings down defenses. This can help them feel safer to talk about the underlying issues that have brought them to this place. Even though you are not responsible for the actual lives of those that you work with, it is our responsibility to provide resources and referrals, and a non-judgmental connection with empathy and validation. If you can facilitate even one good connection between the client and another important person in their lives, that is one of the best resources you can give to them. This is where we truly need the help of a system to ensure our clients have opportunities for help. In this section, we will go over the stages. Just like we have stages of change, we have stages of suicidal behaviors. Ideation is the first stage. When you identify that one is starting to think about suicide, has those thoughts, get them to talk about it. How often do you think of it? When do you feel this way? What's going on when you have these thoughts? Is there a trigger to the thoughts? Like after a fight with someone, after getting bad news, or do you just wake up thinking about it? How strong is that feeling? How long does the feeling last? How many times in the last couple of days? In the month? When was the worst time you ever had ideas about suicide, and how did it make you feel? Planning is the next stage. It's important to ask them if they know when they would do this, what they would use, do they have access to that method? If they don't have access, what do they have access to and what would they use instead? Have they prepared for the method? If they decided to take pills, how many do they have? Do they have them saved back? They're going to slit their wrists? Do they have hidden blades? Have they purchased supplies? Have they driven the route? Behaviors. Have they ever tried to commit suicide before? Have you ever started to try? Have you rehearsed an attempt, like tied a noose, loaded a gun, counted pills, researched how much it would take, written a note, thought about what you would put in the note? What things do you do to stop yourself? Who stops you? What are the thoughts that stop you? What has kept you here so far? Intent. Measuring intent is important. Here's a place where you might include a measure, asking for a number, a percentage of seriousness. 0 to 100%, how much do you think you will actually carry out the plan? Do you expect this to end in your death? What do you expect to happen before, during, and after? What will happen to your family? Who will find you? What gives you hope? This is a place where when you ask the question like, what do you expect to happen? Who do you expect will find you? How will people learn of this? How will they feel about it? Those types of things are ways that will help them think about it a little bit deeper and identify whether this is a rational plan or an irrational plan, and the extent to which they believe they need help. Ambivalence is the uncertainty about living or dying, or which road to take, struggling to know if life is worth living, if it's worth it to die, or if they can live in this life. Do I do it or I don't? How do I do it? This is a time we want to ask the question. Most people want to do the best that they can, but when they feel that they can no longer do a good job at anything, they begin to feel ambivalent about their life. When someone identifies suicidal behaviors or thoughts, it's important to ask about what's good to live for. What do they have to live for? Finding that one thing to live for. Your responsibility. When you're working with people, it's hard to determine the depth of your responsibility for their well-being. Here we're going to explore those ideas. Suicide is a difficult subject and is scary for the person who identifies it in another person. When you identify suicidality in another person, it is your responsibility to offer help. Respond appropriately, talk to them, assess the situation, report it, offer help, take them to find the help, call someone to take them to get help, help them make an appointment with a therapist, remind them of reasons to live, and tell them how it will affect you if they do this act. Follow up, let them know that you care, and create a team of others to help them. What is not your responsibility? This may not sound like an appropriate thing to say, but it is not your responsibility to ensure their lives are saved after you have followed your procedures, helped them to get help, and created a way for them to reach out when they need it. It is not your responsibility to make sure they do not commit suicide. If someone has made up their mind, no matter what you do or say, they will do it. If there is no one they can connect with in their lives, it is not your responsibility to be that person for life. Although we may have the desire to be that person for our clients, it is unhealthy to believe that we can be. Remember, work boundaries are important so you can let go of your work responsibilities after hours to be present in your own life. Remember, you cannot be the sole support for the person who is hurting. We engage others to help them, and it could be harmful to you and your client if you try to be the sole support for them. If advocacy interests you and you want more information on how to become a suicide advocate, contact the American Foundation for Suicide Prevention at this link. It can give you more information on this subject and help you learn how to become an advocate for suicide prevention. Boundaries are a good way to identify our responsibility to self and others. Most places you work have policies about what you can and cannot do in the context of boundaries when working with people. Boundaries are best decided before an incident happens, and it helps us to know what to do and not react to our emotional urges. Setting up boundaries are for the safety of you and your client. Boundaries in the helping profession surround our contact with clients, expectations, what to do when we have an emotional pull with the client, and checking our boundaries regularly. One of the rules for teaching clients to advocate for themselves is to show them how to do it with them, and then cheer them on as they take over as the driver in their life. If you're having an emotional pull for your client, acknowledge it and let it go. Talk to your supervisor or a peer about it. An emotional pull can keep you from staying objective when you need to. Check yourself regularly. Are you doing more work than the client is for the outcome that they want? Or are you working on an outcome for them that they're not invested in? What is the way for them to work for their own outcome? Remember that boundaries are a responsibility to self and to the client. Don't make this your personal mission. Identify your boundaries for safety and for your own mental health. You need them to help you be present and able to help the next person who needs you. Self-care is a type of boundary, one that nurtures you and helps you fill your cup so you can be present in your life and at work. It will help you relieve the stress from working with people who need you, and especially with suicidality. It will help you be the best you can be. If you know someone who's completed suicide or has attempted, do not try to be strong as if it doesn't bother you. Debrief right away. Find something to help you work through your emotions. Discharging any emotions you're holding on to is important. Any emotion you have is normal and will pass, but it will leave less of an impact on you if you can discharge the disturbance from your mind and your body. You may feel concern, guilt, fear, and have negative self-talk about what you could have or should have done differently. Don't allow that to stay in your body. A good way to discharge that from your body is to exercise. When we hold negative emotion, it settles in our bodies, in the tissues, and can cause pain and illness over time. Go to therapy. The more clearly you have processed the event, the better able you are to help others, and you will feel better. If you think you are unaffected, this is a warning sign that you will be unable to help the next person with this problem. Vicarious trauma is a real thing, and it will get in your way from helping others. It's important to address that before it happens. Here is a list of references I used in the development of this presentation. Much of this information also comes from my clinical practice. It is my sincere hope that you have gained confidence and an understanding of how to deal with suicide. It is a real problem over all races, places, and peoples. It was my sincere pleasure to present this information to you, and am confident that you will know how to better recognize the signs and symptoms, know how to assess if someone is serious, and help them access assistance. Suicide affects us all, and it's important to know that you don't have to address it alone. There is help.